medical field. After his qualification of medical doctor at Pretoria University, he specialized in neurology at the University of Stellenbosch and cum laude at that. Dr. Opperman has a strong interest in movement disorders and multiple sclerosis, and he was awarded the FCP Neurology by peer review in 2008, recognizing his clinical excellence. He co-authored the South African guidelines for the diagnosis and management of multiple sclerosis, and he serves on the medical and scientific advisory board of MSSA. Dr. Opperman, thank you very much for joining us, and thank you for gracing us with your presence. Thank you.
Thank you, Christelle. It's very kind words. Okay, so I was fortunate enough to attend ECTRIMS this year, and some things are new, some things are not so new. And I thought Nan has let you know more or less what we're going to be talking about. And let's take you through the lessons learned. Can I have the first slide, please? There we go. So the most important lesson, I think, is that the McDonald criteria have been revised. And although they're called McDonald 2024, they were only published last month. So we have changed the way we will be able to make the diagnosis of multiple sclerosis, not making it more difficult, in fact, simplifying the diagnosis. There are lots of new changes that are very important for us. The first one is we now recognize the optic nerve as the fifth site. We've always known our patients get optic neuritis, but according to the McDonald criteria in the past, the optic nerve was not considered an independent site. But more on that later. So you might find we will be using more tests than we did in the past. In fact, we might be moving back to old-fashioned tests. In fact, before the MRI, the visual evoked potential and somatosensory evoked potentials, those were tests to look for demyelination. I don't know how many of you have had a VEP, or as we call visual evoked potential, but it's a very simple test, not a painful test, where you look at a computer screen, you stare at a dot, and the checkerboard pattern changes behind you. We then can measure the time the impulse takes neurologically from the back of the eye to the cortex. And we know what's normal. And if that is prolonged, it's an indication of demyelination of the optic nerve. Optical computer tomography is something else that can be done. And in fact, we often see an abnormal optic nerve on the MRI. So that's lesson number one. The optic nerve is a new site. That then immediately leads into number two. We look for dissemination in space. And for dissemination in space, in other words, what do we mean by that? You need to have lesions in more than one specific place. That's dissemination in space. Now, optic nerve is now the new extra lesion. All the others are what we've had before. Intracortical or juxtacortical. In other words, contrary to what we believed many years ago, you can have demyelination in the cortex, in other words, in the gray matter, which is highly typical of MS. So if we see demyelinating lesions in the cortex or next to the cortex, in the gray matter or next to the gray matter, that's considered a separate area. Then periventricular, in other words, around the ventricles. A little bit more about that later on. It's quite interesting. Infratentorial, that means the brainstem or cerebellum. And lastly, the spinal cord. So we have 5 discrete areas, whereas up to now we've only had 4. This makes life a lot easier to make a diagnosis. I think the biggest thing on the new McDonald criteria is that dissemination in time is not mandatory. We do not have to prove that you had one lesion a year ago and another lesion now. This is going to cause a lot of interesting issues. I don't know how many of you have tried to claim disability on various insurance companies for your diagnosis or dread disease even. And the older insurance companies still insist on 2 separate of events which we now have got the criteria to say that's no longer necessary. So the one is to convince the medical aides that this is no longer mandatory, which I think is not the hardest part. But the insurers are going to be interesting. The two new things that are very important and very diagnostic on your MRI is what's called the central vein sign. In other words, if you have lesions, demyelinating lesions, with a vein in the very center of the lesion, that is highly suggestive. And you don't need to know this unless you're a radiologist. We need a certain amount of central vein signs. So there can't just be a single one. There need to be a certain amount. And that indicates, because we know, some of you remember years ago, these odd ideas about doing these azygous vein things that people had done, where because the theory came that demyelination occurred around blood vessels. Well, this is quite effective. We do know it occurs around blood vessels, but those procedures made no sense. The next thing is paramagnetic rim lesions. In other words, if we find lesions that show magnetic activity around the outside of the lesion, but not on the inside, that's also pathognomonic of MS. So we've got extra radiological signs, not just demyelination. Still, obviously, what I've not put on here, the old thing is if there's contrast enhancing and non-contrast enhancing lesions, that shows dissemination in time, but it's no longer necessary. There is a new test on the market called kappa-free light chain index, or the oligoclonal bands. In South Africa, we do not have the kappa-free light chain index. For those of you who are hoping that means you don't need a lumbar puncture diagnosis, doesn't make any difference. The kappa-free light chain index is very much like the oligoclonal band test. You still need a lumbar puncture to diagnose it. It's just a less expensive test, and that's why it's been suggested. Lastly, radiological isolated syndrome, excuse me, come have some water, is no longer necessarily a diagnosis. So if someone has an MRI for another reason, they've been in an accident, bumped their head, or they have a bad headache, or for whatever reason, they've had a routine MRI, and they meet the McDonald criteria, that does, however, include the lumbar puncture. We can then call these patients multiple sclerosis, even if they've never had a single clinical episode. This is hugely important for us, because that means we will be able to start people much earlier on disease-modifying therapy. All of these criteria are there to diagnose people as earlier as possible. So the earlier we diagnose someone, the quicker we get them on treatment, and the more highly effective drugs can be used. So we are looking at a brand new criteria. I have to say the radiologists have really been pretty good on the uptake. I've had a couple of reports saying they didn't see central vein signs, they didn't see paramagnetic rim lesions. So it seems as though it's on the uptake. We will spread this to everybody. This was published in Lancet Neurology the beginning of this month. So it's a brand new criteria. So the working group on the diagnosis of MS has got together and simplified this. It might sound complex to some of you, but it's not. It's going to make our life a lot easier, be able to get patients on treatment, possibly before they even have their first episode of demyelination. Can I have the next slide, please? Okay, this might be a little small. This to me was one of my more, probably because I'm getting older and my patients are getting older, MS in the older patient is a pretty hot topic in MS for a couple of reasons. Patients over the age of 50 are often misdiagnosed because we see white matter changes in the brain after the age of 50 for various reasons. I can tell you that at least twice a week, I see a patient who's had an MRI somewhere with white matter changes, and the radiologist hasn't followed the new criteria and suggested that they must consider MS as a diagnosis. These patients are frequently seen, and one needs to reassure them. Sometimes one's surprised. Okay, what causes white matter changes in the older patient? One, small vessel disease. In other words, hypertension, diabetes, elevated cholesterol. All of those are risk factors for getting white matter changes in your brain. Some psychiatric disorders are also associated with white matter changes, and also certain autoimmune disorders. Sarcoidosis gives us white matter changes. Lupus can give you white matter changes. So there's a lot of other conditions that we see in increasing frequency in the older patient. This is where it becomes important. This is probably point number 3, the main reason I see people referred with abnormal scans. And it's also why I hate to do an MRI on a migraine patient. Anyone who has migraine will have white matter changes in their brain, and they're often periventricular. So it's the one area that looks a lot like MS. And although they tend to be smaller lesions, it can sometimes look remarkably similar. So in a patient over 50, how do we make the diagnosis? Well, you need to have a couple of extra features that are important. If there's spinal cord lesions, then there's very little doubt you're dealing with MS, because the above mentioned conditions are very unlikely to give you a spinal cord lesion. The absolute go-to place for me in all my older patients is the lumbar puncture looking for oligoclonal bands. To understand a little bit, what are oligoclonal bands? We're looking for inflammation in the central nervous system that's not in the peripheral nervous system. So that is an indication that there's different inflammatory conditions happening in the brain and spinal cord to the rest of the body. And then lastly, if there's a central vein sign, and there once again, we need a collection of how many of these there are. So over 50, definitely need a lumbar puncture, but I personally now these days do a lumbar puncture on everybody. For me, the more difficult topic in MS in the older patient, and this is more complex for me, is that our older patients don't often have just MS. They might be diabetic, they might be hypertensive, they might have other underlying conditions, they might have migraine or migraine, depending on how you use the word, that can give them white matter changes. So the patient comes for review of their disease-modifying drug. We review them, they get a new MRI, and there's 1 or 2 small white spots. That then has to be interpreted in a much more complex decision. I think in the older patient, if they've not had signs of a clinical relapse, and if they're not enhancing, and they don't look like MS, that they're smaller, non-specific in nature, one has to be very careful about changing a treatment that seems to be clinically working for a patient at that particular point. So MS in the older patient is going to become a huge topic. Why? Because we have such great disease-modifying drugs that our MS population is going to get older, as opposed to what it did when I started in this business over 30 years ago. So MS in the older patient is an absolute reality. Next slide, please. This is, to me, the most joyous part of attending this ECTRIMS meeting, was attending the talk on pregnancy and breastfeeding. Who knew when I started in this business years ago that patients would be having families after the diagnosis of MS? Who knew we'd be planning families, that patients wouldn't have such fatigue or such disability or be on such toxic drugs that they weren't about to have their own family? So this talk was unbelievably good. It was led by a German neurologist who has an interest in this particular field. And some of this is documented and some of this is opinions. So let's start there. Due to the early diagnosis and highly effective disease-modifying therapy, we expect our patients to have normal lives. So, gone are the days where we expect some kind of disability at a point. We now expect our patients to live a normal life and have normal activities, such as breastfeeding, pregnancy. Right, what do we know? Interferon Copaxone and Tysabri are safe during pregnancy. So if you are on one of those drugs and you want to feel pregnant, or you are unsure when you want to feel that you want to, or you're diagnosed and you want to fall pregnant in the near future, those are two easy drugs to start, particularly if you're newly diagnosed. I'm going to go to the last point first before I go to the middle point. A drug like Mavenclad has changed things completely. Because it's a 2-year treatment, we can here plan a family. See a 20-year-old woman, do the 2 years treatment of Mavenclad, and after the Mavenclad is completed, if they're in remission and don't need further treatments in the future, then they start their family without a problem. So here we have a drug that we can actually say, let's go for this one first. If all was equal and we were allowed to start with this drug, it would be amazing. The two drugs that were considered, and in fact, Ocrevus more than Bonsbury, but the B-cell therapies were considered pretty safe to time around pregnancy and breastfeeding. And it's something I've been doing in my practice for some time now, that you give your last Ocrevus treatment, you wait a certain period of time, hopefully fall pregnant as soon as possible. And then up till now, if the patient has done well off the Ocrevus during the time, I reinitiated after breastfeeding was stopped. But in actual fact, the neurologists who presented this both felt that in highly active patients, there's absolutely no reason not to restart Ocrevus during breastfeeding. Bonsbury could probably have a similar place. So here we are looking at a completely different plan here. If a patient has highly aggressive MS, there is still a place to use Tysabri as the treatment through pregnancy. Right, next slide, please. Okay, so smoldering MS is still there. Still a very important topic. What is smoldering MS? That's where both the neurologist and the patient are convinced that the MS is not fully controlled, but the MRI is not giving us that answer. So at this point, what do we do? In countries where they have stronger magnets, you can probably see lesions that we're not picking up. I remember years ago, we also used to say, give a double strength of contrast. I've not heard that used for a long time, but we used to, when we couldn't see an enhancing lesion, we tried double contrast. So we've known about issues where we don't see everything from the beginning. So we don't have 7 and 10 Tesla magnets in South Africa. So we're not necessarily going to see some of the lesions that are not available. In Europe and North America, they will use neurofibrils to look there. Okay, so they will look for biomarkers, which we don't have here. Hopefully we get them in the future. That says, okay, MRI looks stable. We're not convinced you're stable. Don't think you primary progressive or secondary progressive. Still think you're relapsing. Can we do this test to prove there's ongoing inflammation? And hopefully that comes. I do, however, think we should have a low threshold to up escalate. So if both of us are convinced that you're not doing well, what do we do then? This is not a lesson I learned at the Congress, but it's a lesson I've used myself for a long time. If I see a patient and the MRI says they're doing well, and we both not convinced they're doing well, a trial of intravenous steroids, and as you know, most of the medical aids will fund this to be done at home these days. You don't even have to be admitted to hospital. We can then see what kind of improvement. Most of you that have IV steroids know that you feel dramatically better for a couple of days. So the real answer is, how do you feel a fortnight or 3 weeks after the steroids? Do you still feel better than you did before? Are you walking better? Is your mobility better? And that's a place to say, okay, let's up escalate your treatment. Then in smoldering MS, I'm sure you all read about the CAR-T patient that was initiated, the BTK patients. There's lots of things, and stem cell, it's all there. There are lots of new drugs coming. We don't have half the new ideas that are happening. The activity that's there is amazing. While I'm on this topic, I have to say a huge congratulations to one of our colleagues who is a neurologist in Africa, in Zambia, who pioneered getting rituximab on the World Health Organization essential drug list. So we know rituximab is not covered for MS in South Africa because it's not registered. We know it works because the Swedes have proved it works. So there are other issues. So in the rest of Africa, where it's state funded, you might be able to get rituximab. That's a great breakthrough. Okay, now I have a little something to end with. It was not advertised, but this is my most often asked question. May I have the final slide? Remyelination. Okay, there are two drugs in phase 2, clemastine and PIPE 307. Don't know what's going to happen. As you know, we always look at this. We often see phase 2 trials, sometimes a phase 3 trial, and then we don't see what happens there. We don't have a great drug for remyelination. There are two drugs that are in trial as well. One is an antifungal, miconazole, and the other is metformin. Metformin is a common anti-diabetic agent. Now, why have I not put all my patients on metformin? Because of my final thing. The Hippocratic Oath says first do no harm. So I don't know that starting a drug that has got no proof will improve my patient. That was a lesson we learned a long time ago in the late 90s when most drugs were not affordable for our patients. And some of us, you might have been one of the patients who your neurologist suggested trying very high dose simvastatin. We tried 80 milligrams of simvastatin because there was a trial that it might work. There were trials that the HIV drugs might work. Then all of these ended up being negative trials, not for remyelination, but MS control. So I had at least 3 patients we put on high dose simvastatin. And in actual fact, I think we didn't do any advantage to the patients because of the side effects of the drug. So problem is, even in these phase 2 trials, remyelination seems to fail in most lesions. It does, you can remyelinate lesions, but not all the lesions. So these drugs hopefully will come through. So the good news from ECTRIMS this year is 1, we're making diagnosis easier. 2, we're looking at 2 major groups of our patients, older patients and female health issues. And lastly, we are looking at more aggressive, newer forms of treatment as well as remyelination. Those for me were the most optimistic findings of the meeting. There were lots of other things too, Epstein-Barr, lots of things, but this for me was my take-home message that I'd like to share with you. I think my last slide simply says thank you and questions.
And with that, I would like to thank Dr. Opperman very much for his time and his presentation and his insights on this wonderful topic as well. This is quite an engaging presentation, and therefore I would like to hand over to Christelle that will then take us into the Q&A session for today's webinar. Thank you, Christelle.
Thank you. Thanks again, Dr. Opperman, for your presentation. We've had a couple of questions beforehand, so I'm going to read some of them, and then if you can answer them for us. First, we have Karen van Tonda ask, is there any helpful information that you need to know when you have to stop working due to stress?
Okay, so if you're stopping working due to MS, that's easy. If you stop working due to stress, then you probably need to have a psychiatrist or psychologist book you off for that. Your neurologist would not be able to book you off for the stress. They can book you off for fatigue, cognitive impairment, physical disability. But if you're wanting to stop work because of stress, you would need a psychiatrist probably to book you off for that reason.
Thank you. And then next question from Lucretia Timbeni. What resources are available when you are dealing with MS and want advice or have questions concerning treatment, side effects of medication that you are using, or you are unsure about symptoms that present themselves?
So in South Africa, you should speak to your neurologist, speak to the MSSA, speak to the groups. In the UK, they have MS nurses, which is a pity we don't have here, because that's an easy port of call. But speak to your treating neurologist, even your GP, but speak to a healthcare professional and the MS group. They'll give you advice.
Thank you. And then next question, I don't know if we have an answer, from Byron van der Bank. How far are we from a cure for MS?
Well, okay, there's two answers to that. If you respond to Mavenclad and you become disease-free, then maybe you're cured of MS. Who knows? If you respond to stem cell transplant, then maybe you're cured. We have patients who had stem cell transplant more than a decade ago who never have new lesions. So we have 2 or 3. There are other options of potential cures where it's a one-off intervention and rather than an ongoing treatment. I'm giving you 2 examples: Mavenclad, stem cell, where you do something once and sometimes switch the whole process off.
The next question from Maria Munga. How do you deal with the depression associated with MS and the suicidal thoughts?
Look, we are all different. I have as many people who happily carry on with their lives after diagnosis with MS as go into a deep depression. And I think that has 2 reasons. One, to do with your underlying personality, who you are and how you cope in life, and also as to where your lesions are. If you have lots of temporal lobe lesions and frontal lobe lesions, you're going to be withdrawn and depressed. If that's the case, you need to speak to a neurologist, and you should probably not just see a psychiatrist, but actually have a psychologist assisting you with that. Even a life coach, if that works better.
Okay, next question from Helen Nabiswa. I'm looking forward to help educate myself and how to that's not a question, it's just she's looking forward to this. Then from Krista Brower, in the case where a patient has possible smoldering MS based on no new lesions or activity on existing lesions based on MRIs, but they are experiencing continued decline in mobility, will the use of a DMT still be beneficial?
You have to then decide, are we dealing with secondary progressive, or are we dealing with relapsing remitting? And I don't have an academic answer. I'll tell you what I do. I would give those patients a trial of steroids to see how much they improve. If they improve clinically on steroids, then we motivate the medical aid to upgrade their DMT. Also, if they're on a first-line DMT, it's easy to go to a second-line DMT.
Next question from Julie Chari. How quickly can you go to another level? When I started, I was on 2, and now 8 years later, I'm on 3. I'm assuming that's the EDDS scale. I don't know. But she was on level 2 and she's now on level 3. Oops.
I'm back, I think.
Yes, you're back. I can hear your voice.
Okay, I didn't hear that last question.
Okay, the question was, how quickly can you go to another level? When I started, I was on level 2, and 8 years later, I'm on level 3. So I'm assuming that's EDDS scale. I'm not sure.
So if they're talking about the EDSS scale, it depends on your form of MS. I have patients that I've been treating for 20 years that are still EDSS 0.5. And then I have patients that rapidly go to 4.5. It all depends where your lesions are. EDSS is a horrible way of assessing MS. It relies totally on your motor issues. Doesn't take into account fatigue, doesn't take into account cognitive issues. So it's unpredictable who goes fast and who doesn't. And then obviously, if someone's EDSS is progressing, they should be on. Then you need to decide, is it progressive MS or is this relapsing remitting? And then you need to do appropriate intervention.
Okay. I think your camera is off, doctor.
Okay.
Okay, then the next person wants to know, it's from Marion, pregnancy after stem cell transplant and re-immunization after HSC transplant. So I'm assuming she's asking whether she can get pregnant after a stem cell transplant, and is it necessary to have re-immunizations after HSCT?
Okay, so you can get pregnant, obviously. The issue is going to be immunization, because we know you've probably wiped out all your immunizations. So you probably need to be immunized, even for those immunizations that are once off. Like we know yellow fever now is a once-off vaccination. If you were going somewhere where you required yellow fever, you'd probably need to be revaccinated. Therein lies the whole big issue. And we've done this years ago. We did a whole session on vaccination and MS. It's not as simple as you think, because vaccination can trigger symptoms. However, if you had HSCT and you're in the clear, it shouldn't trigger it. So I think the appropriate vaccination should be taken care of.
Okay. And another question from Krista Broer, and this is the last one I have on questions beforehand. What exactly is PIRA? How and why does it happen? Does this only occur with chronic progressive MS? Is it a new terminology for an occurrence that cannot be explained? Can you tell us a little bit more about PIRA?
So basically, PIRA and smoldering MS are the same kind of concept, that you actually have lesions that are active. So we're looking at disease activity. I think the minute we can measure the neurofibrils, it's going to take a difference, because we need the tool. So in other words, we do the MRI, nothing's happening. We do a blood test or a CSF test. Theoretically, if we think, we know some of the drugs, if you do the test and you test for oligoclonal bands and you put them on treatment, and in academic places where they've redone the lumbar puncture after a couple of years and the patient's in remission, the oligoclonal bands go away. Should they then come back, one can also prove you've got ongoing disease activity. And ongoing disease activity, the drugs are getting cheaper. There are more and more options. I mean, if you think about it, we have such a vast array of drugs. Don't quote me on this, but I still don't believe MS is a single disease, and that'll come out one day. Why do T-cell therapies work for others and B cells for others and this for others? And I think that's the whole secret.
Okay. Thank you, Doctor. I've got no other questions that came up.